is the talk I'm going to talk about is the low dose rate or in general about brachytherapy treatment. So thank you. So I start with my slide. So I move on. Um, so just 1 second. Let me check it. Yes. Okay. Perfect. So today I'm going to talk about localized prostate cancer. You have heard the talk from previous speakers about radiology, PSMA scan, and from Dr. Mohammed Shailan about all treatment options. However, the brachytherapy options is more limited to localized prostate cancer, as Mohammed Shailan mentioned, that is not used for the metastatic cases. When I talk about the brachytherapy, I will talk about mainly low dose rate brachytherapy and some of the differences with the high dose rate brachytherapy. So we touch on both topics. So we all know that brachy is a Greek word which is brachios, and that means source is close to the target. And if we can place the source closer to the target, then we can actually this is what we call it as brachytherapy. Um, that there's a big difference in brachy and external beam radiation. So external beam using linear accelerator to give the radiation externally, it may have more exposure to healthy tissue. However, the brachy is completely different in this sense that the similar radiation is given to the target itself or very close to target. So we expect that integral dose is lower than external beam radiation. I will talk more about that, but brachytherapy can be used as its own as a primary treatment, or it can be combined with external beam radiation treatment. There are some examples of brachytherapy. Of course, we will be limited ourselves to the prostate brachy, but just a quick glimpse of it is that intracavitary, for example, cervix cancer, we use very commonly, integral part of the radical treatment. Interstitial temporary brachytherapy can be prostate like HDR, or breast cancer, again HDR, skin cancer, gynae cancer, and it can be combined with intracavitary as well, like in the gynae cervix cancer, where we do both intracavitary and interstitial brachytherapy. Now, there are interstitial permanent brachytherapy, where like prostate seed implant, permanent, and also breast seed implant are permanent. We can use mold or plaque brachytherapy for skin cancer, for eye, for breast cancer, and in a balloon form, like the combination of balloon can be used like Savvy applicator for the breast cancer treatment. So brachytherapy has multiple use. It's the first treatment actually for the radiation, and now we are only using it for the combining with external beam or as a primary treatment. So now for the rationale is this is the first and probably the ideal form of conformal radiotherapy. So this is the single most advantage of the brachytherapy, that it deliver radiation conformally. Then it also able to deliver very high doses of radiation when we know our target, and the dose fall off is very steep. So if when we place the brachy sources close to target, beyond target to the healthy tissue, the dose fall off is very rapid, so the exposure is less. And it is ideal treatment for the cancer, which is clinically and radiologically well defined margins. For example, prostate gland is a small gland where you can deliver the brachytherapy and the fall off is very rapid, which save the bladder and the rectum. So there are some really kind of advantage of brachytherapy in this area. And it is a preferred treatment when you know your CTV is certain. If you don't know your CTV is certain, then you can now, the concept is changing. You can combine this with external beam radiation treatment, and you can actually then you can actually combine with external beam. But however, if you are sure about your cancer limited to prostate gland, then you can actually be able to only use brachytherapy. So it is also very effective treatment for low grade or early cancer where it's localized. And it is very critical to have a good distribution of sources, because if you don't do a good implant, the geometry will be very difficult to correct. And that's how you need some training or some understanding of this cancer. So anyway, so for the brachytherapy. So now the thing which you can control in brachytherapy, there are things you can control while you're delivering the brachytherapy treatment. So the principles of brachytherapy is that it treats small volume to very extremely heterogeneous dose distribution. So if you are looking into something which is called conformal index or conformity index, it will not be the best because the CI ratio will be worse than external beam. However, it will deliver the higher doses to the target directly. So therefore, it is an advantage. So heterogeneous dose distribution is actually an advantage. And if you look at, I give you example of prostate cancer where we prescribe at 145 gray, but average dose is above 200 gray. This is because of the heterogeneity of the dose distribution. So this can be a disadvantage, which actually turns to an advantage for brachytherapy. Now there's a volume effect relationship. So if you're going to be too big of the volume, then brachytherapy, of course, is not the ideal treatment. It's better to have a smaller volume, confined target, and you want to deliver radiation to that target. After moving from that, I would say that brachytherapy, when it comes to prostate cancer, it can be monotherapy, means only treatment by using brachytherapy, which I mentioned to you. It can be combined with external beam or it can be just its own. So monotherapy in low risk and intermediate risk, this can be an ideal treatment if patient is eligible. And low dose rate brachytherapy can be delivered as monotherapy, which we prescribe usually to 145 grain, one single setup and one single fraction. Actually, people who live distance from cancer center, they love this treatment for this reason that they have to do only one visit instead of multiple visit to cancer center. The high dose brachytherapy as monotherapy is a new entry. I must say that there are studies undergoing. There are phase 2 studies or phase 1 studies which shows that HDR brachytherapy can be a monotherapy, but there are randomized comparative trial going on with low dose brachytherapy, which is considered as the gold standard for monotherapy, and comparing that with the 2 sessions of high dose brachytherapy. This is the reason is because there was one single dose of high dose brachytherapy was utilized using 19 gray, with the outcomes were inferior. So it was thought that how about if we split the doses into 2 sessions and we do that sessions 1 or 2 weeks apart and treat HDR brachytherapy, and the results are quite convincing, and now is underway for the randomized studies form to test that to become as a standard as well. So for monotherapy, we have low dose rate brachytherapy and high dose rate brachytherapy. The difference is low dose is 1 session and high dose is 2 sessions. And high doses still need to have some more data to mature and some more study to come. Now I will talk about something combining brachytherapy with external beam radiation, especially trimodality treatment. So in intermediate risk, you can combine only external beam and brachytherapy without hormone treatment. Which can be with the high dose rate more, because trimodality, the only external beam and brachytherapy, when it's tested in external beam radiation versus brachytherapy alone, there was no advantage of combining external beam with brachytherapy, and brachytherapy alone give similar results, and there'll be less, and it was less toxic. So I prefer monotherapy for LDR, but when I'm talking about trimodality, this is a very new direction which we have in the horizon. And actually, some people were thinking the brachytherapy is dying off, but actually, after all these new studies, brachytherapy is going up, and it would need to be must part of a system like the gynae brachy. So trimodality treatment, then when we combined external beam radiation treatment, like high tier intermediate risk or high risk, with the brachytherapy treatment. So external beam can be 46 gray or 45 gray and 23, 25 fraction, or a moderate hypofractionation, which is 37.5 gray and 15 fraction, commonly used in Sunnybrook. And the brachytherapy boost can be either HDR, high dose rate, as single 15 gray fraction. It can be given before the external beam radiation, or can be given after external beam radiation, and they both come out to be similar results. So the timing of the brachytherapy for high dose rate brachytherapy is not affecting the outcome or toxicity. So for HDR, it can be delivered before brachytherapy and before external beam radiation or after. In low dose rate brachytherapy, this is a little bit different, because of the studies done low dose brachytherapy giving 110 gray compared to 145 when it is monotherapy, this is always given after external beam radiation treatment. Um, and that was the reason is because brachytherapy, low dose rate deliver radiation, deposit radiation over a longer period of time with half-life of 2 months. And up to 6 months radiation can be delivered. So we don't want to have concomitant both radiation treatment. So therefore we finish external beam and then move on to low dose rate brachytherapy. However, HDR, because it deliver at that time, can be given before external beam radiation as well. So hormonal therapy can be combined with them. And there's an important point I want to touch in here, that any study done with brachytherapy as a boost, as trimodality or bimodality treatment, the hormonal therapy duration was reduced in those studies. This is maybe because of the dose intensification. We know that the brachytherapy deliver higher doses. That's what I established, and I was talking to you in the previous slides. So by doing that, we are doing an intensification of radiation dose. And this may cause us to not to give longer duration of hormone treatment. And it is very important because hormonal therapy can cause a lot of metabolic effect in the people. And if it is longer term hormonal treatment, sometime I don't even recognize my patient. They look a little bit different after long time hormone treatment. So anything which can cut down the hormonal therapy duration, I would prefer it. And in the studies I will show you in my next session, because I'll come back in section of session, I'll show you the hormone duration can be reduced if we are using external beam combining with brachytherapy boost. So now I will talk about, so this is what general points about the brachytherapy for low dose rate and high dose rate. Let's move on to low dose rate brachytherapy treatment for prostate cancer. So brachytherapy, one of the disadvantages actually, it is not for everyone. So there are some eligibility requirements. There are some indications. So if we look into indications, monotherapy can be given to low risk or intermediate risk category patients. If we want to go for high risk patient, then we need to use external beam and we need to use the boost, brachy as a boost. And also very, very important indication of brachytherapy, which is emerging more and more for both low dose rate, and it is established for low dose rate and it is emerging for high dose rate as well, is salvage brachytherapy. This is when people have received the radical radiation and they focally failed in prostate cancer, biopsy proven with no distant metastasis. They can be salvaged with very good results of curing them and very tolerable side effects profile. It is one of the options for salvage. However, to me, this is one of the best option for the salvage. Now the requirement. So there are some requirements, not if the patient is not fit for anesthesia, cannot be a candidate for brachytherapy. There should be acceptable obstructive urinary symptoms like IPSS score. There are some people who do urodynamics study. Some people just only record IPSS. To be honest, in my opinion, it does not relate to toxicity after implant treatment. I tried to correlate the implant, post-implant urinary symptoms, and I could not find IPSS relation or urodynamics study relation or even dose distribution. So to me, it's like relative term. And if patient is fit, I would still proceed with that. This is also, we pay attention to it because brachytherapy may give more urinary symptoms. Now, if patient have large TURP defect, they should also not receive brachytherapy. However, minor TURP or laser procedures, I've done seed implants and they tolerate it very well. Also, the prostate volume is important. And again, as I mentioned to you, urinary obstructive symptom is relative. Same thing in here. The gland size should not be too small, because if it is too small, then dosimetry cannot be controlled well and it become a hot gland, and that can cause problems with the side effects. And it should not be too big of a gland. Now, I wrote 60 cc here because this is what most of the international guidelines wrote. But for my practice, 65 cc is very usual. And I have done the implant up to 80 cc of the gland as long as arch of bony arch. Pubic arch is not interfering on the path of the needles. And there is another way, if the gland is bigger, by giving the hormonal treatment as neoadjuvant treatment for short time, like 1 to 3 months, the gland size can reduce up to 1/3. So for example, a patient who have 90 cc gland, I'm almost sure that if I give the hormone treatment, then it will become 60 cc, and that way I can do the implant. Also, the prostate gland should not be too long, and again, is very relative. Usually, the gland mostly qualify for this 5 centimeter length. And it should be a favorable anatomic relationship. And that what I mean is that some people with short stature or very tight, narrow pelvis, they may have the bony pelvis in front in the path of needle, which is transperineal insertion of the needles. Those patients are not eligible. They are very few in number, like it would be less than 10%. Also, if the rectum is too close to prostate or bladder, or which is like really, I didn't come across any of those issues in my 15, 20 years of practice. So mainly it is about the bony pubic arch. So I would say this is a patient-centered care. This is a precise treatment. It's customized for each individual. We deliver customized doses to each person, each patient. That is what the wish of every doctor. It's more control on dose parenting. So if you want to boost the dominant lesion, Dr. Abdul Basit and Dr. Sharjeel Usmani mentioned to you that how they can find the dominant lesion on MRI or PSMA scan. And if you have those available, you can fuse with your plan and you can paint higher doses. So very natural and easy way of doing the boost treatment. This will give high average doses to prostate. As I mentioned to you, 145 gray prescription give us average dose to prostate gland of 200 gray or more. And it is low integral dose, as I mentioned to you, compared to external beam, that if we give the radiation, the dose fall off or dose gradient is very rapid and not like external beam. And therefore, the critical structure or normal structure around prostate gland, they receive less radiation doses. Now that it is efficacious cancer control, so cancer control is at least equal to any other option, or in my opinion, better. I may be a little bit biased here, but I think is better. PSA fall rate is very rapid in this treatment compared to external beam. If a patient is eligible and I have this procedure available, I actually prefer the brachytherapy. That's what I notice in my practice. And then this is a minor procedure. It's less invasive compared to surgery. It's only a few drops of blood can come as a short procedure. And actually, to be honest, when we compare with surgery, after surgery, about 1/3 of the patient may require salvage radiation or hormone treatment. And with that salvage treatment in those patients, when it is required, the outcomes are very similar. So this I must explain to my patient when we discuss the treatment option. So it is a patient-centered care, in my opinion, because of the favorable toxicity profile. As I mentioned to you, that urinary symptoms are slightly higher, which can be managed by medication, usually to resolve after some time. And then but it gives very low proctitis rate. I don't recall any of my patients who have the proctitis. If we are very careful in doing the planning and also dose and the seat placement, proctitis is not a challenge compared to external beam, where proctitis can be a side effect. Incontinence is rare. I didn't hear anyone. It actually more obstructive symptoms than the incontinence. So compared to surgery, this issue is not there. And there is sexual dysfunction as with any other treatment, but this, in our opinion, this is the least in the brachytherapy treatment. It is a convenient treatment. Nobody can challenge that. Single day procedure compared to up to 40 visits in external beam radiation. There's no hospital admission compared to surgery. Now, even the surgery improve, and robotic surgery is reducing the time stay in the hospital. However, not still both treatment not as convenient as the brachytherapy treatment is if patient is eligible. So cost effectiveness, this is one of the challenge actually, because it is a low cost to patient, but some centers may want to have the cost or may want to have the revenue. So that's the challenge, that not every center is much interested in this. However, it costs us low. You can save the resources. You can save the patient cost, their visit. So this is like actually you can take off from your linear accelerator machine for 40 sessions, up to 40 sessions of treatment by one session of brachytherapy. So that's very cost effective. There is, and guess what? There is no motion management required. So we're struggling for external beam a lot, a lot. We're talking about cone beam treatment. We're talking about ultrasound verification. We are talking about fiducial marker. How many things we're talking about just for the motion management, because there are interfraction motions and there are intrafraction motion. We have the tools for interfraction motion, but we don't have many tools for intrafraction motion. And there is no motion issues. Once you leave the seed inside the patient, it actually move with the prostate gland. So there is no need for any cone beam CT to verify the positioning. So that's a big advantage in my opinion. Now, this is a mobile unit. So, for example, you are sitting in a big city. For example, I give you Pakistan example. You're sitting in Karachi and you want to go Dadu or Sangar sometime to go and do the implant. You can take the whole unit with you, and all you need a small room, which is clean room, not even operating room. And you need anesthesis, and you can perform this procedure. So with the same unit, you can go around and you can treat people. So that's a big advantage. Also advantage for people to come to the center, because if they're coming from far distance, they can be treated in one time. So, all the good things I told you, but there are some challenges. Nothing is without challenge. You have to do effort for everything. So medical expertise is one of the biggest challenge for brachytherapy. And in my opinion, this is one of the leading cause that brachytherapy treatment is going down around, and it was never was in our region, and now it is available, alhamdulillah. And so medical expertise required, because I did, for example, for LDR brachy, 1 year fellowship to be trained. And if I'm not going to train the other trainees, then this will die off. If I would not be able to function anymore, then this treatment will not be available by one person, will be off. So we need to increase that by training the junior staff in this area. And it is must component of the training, at least in Canada residency program, to know brachytherapy, at least to basic level. There are some high urinary symptoms, as I mentioned to you, compared to external beam, but we can manage that with medication. And in my next talk in the afternoon session, I will talk about them and I'll talk about their remedy. So it's very manageable. And as I said, it is not for every patient. And when it goes in the news in the country where I started LDR, there are patients who come to ask me for brachytherapy, but they were not eligible. So this limitation we need to keep in our mind, that is not for every single patient. There is an aesthetic requirement, not operating room, but a clean room requirement and an aesthetic requirement. And there are precautions, because the patient have to be away from pregnant ladies or children for some time, like an arm distance. And when they travel, if they're traveling to a very sensitive airport where they have radioactive sensitivity, we give them a card to be with them as a precautions, because it may alarm a nuclear alarm or something which can create a panic at the airport. So now the adverse effect I just briefly mentioned here, but there is full talk in the afternoon about that. So it will be like dysuria, retention, urgency or frequency, erectile dysfunction, GI is not there. I must mention about fistula that happened to 1 in 500, but when it happened, it is very devastating. So this, I always inform my patient, this is a risk. They have to choose after knowing that, although it is very rare. So now what are the equipments required? And I would actually show you after my talk, at the end of the talk. So if you can bear with me and hold on, after the talk finish, I'll show you all this equipment live, which because we are performing this procedure in our center, and I have those all this stuff around with me. So if you see in the left corner here, this one is actually the probe. I don't know whether arrow is appearing to you as well. I think not. So very left is ultrasound probe, and that is nothing different from any other probe. So this is an ultrasound probe which is biplanar. So it can show you transverse, and it can show you sagittal. And that's help a lot when we do biplanar. You can do on one plane also implant, but biplanar help us to move, and we can switch between sagittal and axial. Next to it, after probe, there you can see the whole system of an ultrasound system. So there we have the screen. You can see on the screen prostate is displayed, and we have more controlling monitors like a touchpad, and you can control the images from there. Next to it, you see the templates. There are two templates. It's actually not two templates, it's actually two sides of the template. So one side of the template you can see in one image, another side on the other image. So this template go on the frame, and what I will show you as well. So this template is to guide the needles because this will match with what is appearing on the screen. So very important to know. This template is showing wherever you want to. There is a template on the prostate gland and you want to go like specific location in the prostate gland, you can see where this A, B, C, and 1, 2, 3 is appearing, and you can target that specific location using this template. So template is external and prostate is internal, but is matching so well that we are like millimeter accuracy. So that's how we can perform brachytherapy accurately. And then you see there are two plastics, one plastic written top is actually a plastic cover for sterile procedure, because while we are doing the procedure, we are sterile, using everything sterile. So that's how we cover it. And and there's a condom type balloon, which is used on top of this ultrasound probe to have some saline to make the images better. Now move to down, actually, the bottom image. And then I'll come to the very extreme right. So bottom one is actually frame. I will show you them as well. So these are the arms which will be attached to the bed of the patient. And there's two handle. If you see, it's like a navigation. You're like doing the fly airplane or whatever, or you're steering. So these are the steering. And there is a base. In that base, we put the ultrasound system, which will actually flexible in many, many direction, many angles. And with that angle, we can adjust and put our probe into the rectum of the prostate. Now you come to the top image on the very right end. This is the combination of all of them, which I just talked to you. So you can see the frame in the bottom, which is attached to the bed. And this can be mobile. You can move it. You can navigate it wherever you want, like you're moving steering. Then you see the base, actually, where this the everything ultrasound probe is placed, and template on top of that. So these are all combination of everything which I showed you. So with these equipment, I'll show you live as well later, and then we move to what type of planning approach. Now there is full talk by Prof. Pignol about the planning. So I would not talk to you about how to plan a brachytherapy, but I will tell you what type of plan. I think he will mention that as well, but in case if someone will not be able to attend that talk. So one plan is intraoperative. So that is when patient come into the into operating room, we set up, and then what we do the plan, and we deliver brachy then and there. So it's only one setup. Patient will come one time, and then you can implant the seeds. So that's preferred if it is available. The other option is when patient come to you, you take the ultrasound images, you draw the volumes, you plan the patient, so you have lots of time. It take about pre-planning, which doesn't need any anesthesia, take about half an hour, and you take the images, and then you have your own time. You let the patient go home, and then you plan your own time. When the plan is ready, you order the seed, and seed come for a specific day when patient come, and you implant. So there are two methods of LDR brachytherapy seed implant. One is intraoperative, one setup, or pre-plan method, which is like two setup. Now the one is the interactive I wrote here. So the interactive is basically periodically while we do the implant, we keep checking, and that will be applied to both intraoperative and pre-planning. That while we are doing the implant, we keep looking at, and if we need to revise our plan, we can revise to adjust if things are slightly different than what we anticipate. And there is a dynamic dose calculation. While we are interactively looking at, we are having the dynamic images where the actual doses which is delivered now is shown. So I want to raise a point here. This is like an adaptive radiotherapy, online, virtual. You are delivering radiation, what you're seeing, it is delivered that way. So that's a very important point to know. A lot of external beam challenges like motion management, dynamic delivery, and also the adaptive, all incorporated in brachytherapy without any extra effort. So now today I will talk to more about pre-plan study, like two-step, and this is what we do at the moment in our center. What our intention is to move to intraoperative one setup. So when we do eligibility or pre-plan study, this is the first time when the patient will come for the assessment and the planning. So then this is like what mostly done by ultrasound setup, the setup I just showed to you, but it can be done by CT scan or MRI. And we prepare the patient with enema before this process. By enema, we empty the rectum and we ask patient to drink water, or we use catheter to put some saline in the bladder, because air is the enemy of ultrasound and water is the friend of ultrasound. So we prepare this way. Then we do the conscious, some patient like I do when patient is awake, but some patient, if they are very anxious, then you can do in conscious sedation, or even some people use anesthesia, even though it is not required because there is no invasive procedure here. It's only a probe in the rectum. So we put the patient in lithotomy position. We visualize the urethra. There are multiple methods of visualizing urethra. Some people use catheter. However, the disadvantage of catheter is that it distorts the anatomy of the patient. So that means urethra not the same position naturally because of the catheter in. Also, the image on ultrasound is being affected by the catheter. So what I use the method is that I use KY gel, aerated KY gel, we call it. So we take 1/3 of water, 1/3 of KY gel, and 1/3 of air, and mix that. That make a very bubbly white color solution of AY gel, and I inject that in the urethra and then clamp the urethra. And by clamping that, holding the KY gel into the urethra, and this urethra is very bright on the ultrasound images. As you see on my right, the middle image is showing the white spot. That's the KY gel, aerated KY gel, and it's very bright on the system, and it does not distort the anatomy of the urethra. We clear any rectum in the air, should not be because enema is given, but in case if there is, we can use rectal tube and suck that air. And we need to assess the pubic arch and volume of the prostate. Now I'm showing one image here, which is the worst, which is on rarely. That arch is very tight. So if you look at the bottom image, you can see the bony arch like a mountain very clearly, and I draw that. And when you go deeper into the prostate on the very top image, you see that arch was on the path of the needle. So this patient is not the best patient for the implant. However, if it is be only touching a little bit at the edges of the gland, we can always push the knees towards the chest in lithotomy position and push the arch above. So there are some manipulation can be done, but if arch is grossly covering the prostate gland, then it's better not to offer that patient as brachy. And as mentioned about the volume already, and I talked to you about that, how the cytoreduction work. So these are some images. Again, as I told you, I will not go into the planning, but I just showing the some planned images. So prostate is red color, and cyan or magenta, I'm not good in color, is the PTV, and the seeds are appearing like dots, and the colors of isodose are appearing around in the thin lines. And prostate is very well covered. Urethra is in the middle, which is green color, is saved, and there is 3D images. So mid gland image, base image, apex image, arch is drawn by the purple color. And if you see the bottom images, two of them showing the seeds, urethra, prostate, and rectum, which we draw on the images. So this is just to show you, and more details will come later. I mentioned to you that we can boost. So if you look at that, the peripheral zone, which harbor the most of the cancer, is actually receiving the most of the radiation dose. And if I know where the tumor location is by PIRAD or by the PSMA PET scan, I actually put the seed in there, and I get actually 200% of the dose. If you look in here, the yellow color is 200% of the dose. So I actually boost to not 145, which is the prescription. I'm boosting the tumor by 290 gray. So hold tight, it's 290 gray. And if you talk about 150% of the dose going to the whole peripheral zone, the cancer is going to be all dead, and the green is covering the entire gland. So dose bending is an option which is very challenging in the external beam radiation. Now MRI play a good role. We know that soft tissue delineation is better on MRI. That's shown by the Dr. Abdul Basit as well. So fortunately, we have MRI facility here, which is called simulation. We can take the MR simulation, and our VeriSeed software have the fusion facility. So every time when I take the ultrasound or take the MRI on MR simulation as well, even if you don't have it, this is not the mandatory requirement for the prostate cancer brachytherapy seed implant. However, if you have it as an additional advantage, then when I draw the volume, I based on not only ultrasound but MRI as well, and I can show you in the toxicity time that why it is important and how it helps. However, this is not mandatory. So we have that facility, but when you have diagnostic images, be careful in fusing with ultrasound, because diagnostic images are taken as oblique, and MR sim we take as axial image. So that's also important to know. So with this now, we move on. So I explain you all the equipments, steps, and now we are going into the implant procedure itself. So we go to the operating room or we go to the clean room, procedure room. Either way, it is fine. We can do implant day by general anesthesia or by spinal anesthesia. Both is okay. I prefer general anesthesia because we want to have patient pass the urine before they go home, because this is a day procedure. So they have to go same day home. With the spinal anesthesia, sometime we notice that patient may not be able to pass the urine and we have to send them home on catheter and bring them back next day to remove catheter. So therefore I prefer general anesthesia. Also the movement is spinal anesthesia. Patient may be aware of what's going around, and general anesthesia not. Now but some patients are not fit for general anesthesia, then we do spinal anesthesia. Repositioning. So I mentioned to you that we do the pre-plan study. So we did that, but the patient come for implant. Not necessarily the prostate will be exactly on same position. And this is one of the disadvantage of pre-plan in compared to intraoperative. Intraoperative, you see, you do, and you finish. Here we have to reposition prostate to the same way as it was at the pre-plan study. Sometime it may not be exactly same as like my last patient, but then you reposition, you set up your thing, and you get the dynamic dose calculation and you manage. That's what you learn. And therefore, we need the skill training required to face that challenge. Now, once we match the pre-planning images as it was and we are comfortable, physicians comfortable, then we put the template on and we take the needles, and needles are like, you see the needles in the image, but I'll show you the actual needle as well. And those needles have the seeds already preloaded in them. So they come in as a package by mail to us, prepared, that sometime maybe 20 needles, for example, with 80 seeds. So the 20 needles have some spaces with the needles, with the seeds. And those needle and seeds, we would start implanting in the procedure. Remember, when we put the poking the needles, these are pink needle size, like when we draw the blood, pink needle, that size. So there may be some swelling, there may be some gland movement during poking the needles, that we need to continuously monitor by using dynamic dose calculation. There are some extra seeds which we can put as well. So when we start the procedure, we do that put all the according to the guideline, like when we pre-plan, we know at point A, at 1, we need to put this many seeds and needle number this. So we loudly announce needle number 1 with 3 active seeds at small a1 or small a2 or whichever. So we coordinate the template. We coordinate the template between A, B, C, D, E, and up to F, and also 1, 2, 3, 4, 5. So we coordinate, and we use the coordinate with the help of therapist. Physician place them by checking every time on ultrasound, dynamic, actively, same time. So when we place the needle, we see them on ultrasound and we drop the seeds where it should be. So that's going to be very accurate procedure. And we have extra seeds. Usually people order some extra seeds and extra needle in case if the procedure need something extra to boost or something extra missing part. The whole procedure of implant take about 1.5 hours. So it's very kind of time effective as well. Again, my interest is not to show you the plan, but this is a pre-plan study, and I want to show how they're different from the post-plan. So it may not be exactly what you did in the pre-plan. So here is a pre-plan. You saw the prostate gland, you saw the urethra by green, and you see the dose distribution, and you see the arch by purple, as I mentioned to you before. So 150% is pink color, red one is 200%, and green is the 100% dose. So we boost those areas by 150 and 200% of the dose. However, we are avoiding the doses to the urethra. You see the coordinate in the template from A to G, and you see from 1 to 6.5. This is the template which guide us where exactly and how much deep in the prostate gland, at what location, and which needle number with how many seeds we should drop. So this is a kind of active 1.5 hour where we work on this. Then this after implant, these are the CT images of the patient. We want to confirm what we planned, did we deliver? This is the same patient, by the way, which I show you. That look very ideal, covering everything nicely what we want. The actual pictures may not be exactly similar, but very acceptable. So if you look in the same patient, when you look at the axial image, sagittal image on the lateral, green urethra, red is 100%, that is the prostate, and thick red is 100% isodose. And if you look at the pink as the 150 and green as 200% of the dose, now you see that urethra is avoided by 150% isodose and 200% isodose. However, prostate get that doses there, urethra is saved. And this is coronal, axial, and sagittal images. Also, I show you just a bony view and see the seed distribution. If you take an X-ray of a patient, a fluoroscope of patient, how the distribution of seed look like. This is the same patient which I showed images. So this is post-implant day 0. Now, when day 0 is with the swelling as well. So gland size is a little bit bigger. So most of the people do day 30 images. But if you do day 0 images, and if it is covered, it means day 30 will even be better. And if you look at the isodoses appearing on the right side by prostate gland is covered for T90, which we look for 114% of the dose. So we want to give at least 145 gray to 90% of the gland, but actual fact, it actually received 114%, so higher dose. And the mean prostate dose in this case was again more than 200 gray. And this is post-implant day 30. So after 30 days when swelling settled, actually the dose distribution improved, but you see a little bit of minor seed movement here and there. However, overall, the coverage actually improved. If you look at the red color, that all doses actually increase a little bit because swelling settled. So this is post-implant day 30 images. Now here is a video which will show you how the process works. So there's our therapist, Mulham, who is taking care of the machine. And here is myself, which you don't see my face, my hands, and Dr. Jamsari is giving me the needles. I'm being told which level, and is the coronal view, which we did. Then I use the frame and I need to move. If you look at the needle going on the screen, sagittal view, and I adjust, and then I move, scrolling move, and then I take the stylet out, drop the needle in, and take the whole needle out. Here is our physicist who was checking the dynamic plan, and he was checking is that everything is on place or not. So that's a short movie actually for this. Then we come to this high dose rate brachytherapy. Few slides for high dose brachytherapy. Actually, I bring it here because they're not really different from the low dose rate brachytherapy. So they are just slightly different. So equipment are the same. The only one thing which need to be is different is actually the software. That's it. And the plastic tube to insert. So if you have those things in there, then you actually do the HDR brachy as well. So I'm waiting for those things to come to me, just only a software, and then I'll be starting the HDR brachy in my center as well. However, it is already in place in Saudi Arabia and UAE by Dr. Saad al-Rashidi and Dr. Irfan Rana in Medical Clinic Dubai. And also SIUT is going to restart. They were doing it before, and SIUT in Karachi is going to restart again. There may be some other center. I heard Iran also doing the HDR brachy, but I don't know the details of it. So this is more common, so I bring it here. As I mentioned to you, high dose rate brachytherapy as single fraction cannot be standard. This 119 gray single fraction was tested and come inferior. So that's out of the question at the moment. However, what we can do is that we can deliver that treatment in 2 sessions, 1 to 2 weeks apart. And there are ongoing randomized trials to confirm that this is equivalent to 1 session of LDR brachytherapy, which appears to be. So far, studies are very promising. Then it can be used for booster treatment, so external beam radiation. which can be either moderate hypofractionation, 15 session, or 23 to 25 session, and then single boost by HDR of 15 gray, either before external beam or after external beam. It can be used for salvage. As I mentioned, that brachy seed implant can be used for salvage. There is RTUG 0526 study. I will show you the results later. This is also HDR brachytherapy can also be used for the boost treatment. There are some advantage and disadvantage even compared to LDR. You can do the dose optimization. So you see what you're treating. So this is the advantage of, of the HDR brachy, that you can optimize the dose. You can control the source, how long to stay at what location to get what doses, like gynae brachytherapy. It is cost effective, even more cost effective for the reason that every center who have the setup for gynae brachytherapy have the radionuclide already in their system, so they can use the same one. So it is cost effective. They don't have to purchase extra except the equipments. There is also expertise requirement. However, I would say that it is more easier procedure than LDR brachy, because the dose optimization can help them to have less ideal locations of the needle. There is favorable toxicity profile. My colleagues who are doing HDR brachy, they are claiming that we are less toxic than LDR. This we have to debate that. And this there are disadvantage of that. It has to be multi-fraction and not monotherapy. There should be some research into combining it with some other options with in single fraction. So the HDR brachytherapy can be done a CT based or an ultrasound based. Very important to understand this. In past, we were doing the CT based. Many centers have capability to do the CT based. However, CT based have its own challenges. That the needle, when we place in the operating room and we move the patient to bring it to treatment room, by then many times those needles shifted. And on the graph, if you see on the right in this field, is published data from the Sunnybrook that shows that needle displacement, which can be in some cases very long, but easily up to 15 millimeter, which is like 1.5 centimeter. Then they have to readjust and they have to retreat, but we're not sure that we are treating what we are seeing. So that's the challenge with the CT guided or CT based HDR. And therefore, most of the center, if they have facility, move to ultrasound guided brachytherapy. So all the equipment I showed to you, all of them used for the same procedure. Only difference is instead of putting the seeds by using the needle, we use the plastic tubes and connect them with the connector. So this is not much different. So I would show you this movie, which shows the needle placement using templates. So you see the ultrasound already in there, template already there. Some needles were already there, and you see the ultrasound picture on the dynamic ultrasound picture on the right upper corner. You can see needles there. So wherever you're placing needle, you can confirm them on ultrasound that you are on the right location. You're not in the bladder. You're away from urethra, and you look at the images. So when we scroll the images, you can look at in there. These needles appear as the bright spot in the prostate gland, and this way it's pretty straightforward, and you can place all the needles. Now here, so what you do after you place the needle, you draw the ultrasound. You draw the on very left corner of this slide. Draw prostate like red color, and urethra like the sky blue color, and then with that you draw the rectum as well on the second image from the very left. You can see the isodoses distribution. You manipulate, you reduce the dose to the urethra. Your 150% is the sky blue color, and then you actually cover the whole gland, including urethra. However, the high dose area is saved, and you can see the third image from the left is actually cloud, which shows the lines. Yellow lines are showing the tube's position, and the green cloud is showing the dose distribution. And then when we do all that, then we connect. And if you look at the last image on the right side, where all the tubes are connected to the source, like gynae brachytherapy, when you do interstitial gynae brachy, you connect to the source and you go out of the room. So you are seeing what you're delivering. So you start the treatment, within few minutes, treatment is delivered. And again, this is a very robust procedure. It takes about 1.5 hours, and you treat what you see. The only disadvantage of ultrasound based is that because probe is in the rectum, so rectum come closer to the prostate gland because of that, and you see that rectal dose slightly higher than maybe compared to the CT base. However, there are so many other advantage of ultrasound that is over exceed, and the ultrasound based treatment is actually preferred. So what are the evidences? I talk about, okay, this is the procedure, but how to prove that monotherapy or combination is good? So first I talk about monotherapy evidences for LDR prostate brachytherapy. And that is, if you look at this is very, very famous and very common slide utilized or used by many people around the world. There is no randomized trial comparing head-to-head external beam radiation with brachy or surgery. So in Alberta, I can tell you share my own experience. When I try to open a randomized trial, it closed very soon because only few patients who were willing to choose to randomize to one of the option. They actually come up in their mind with either to choose brachy or external beam or surgery. They were not preferring the to randomize, and we choose their option. So there is no head-to-head comparison. However, Peter Grims from Seattle, who have long experience of brachytherapy, he did a good effort. He plotted the graph of the people who treated in low risk and intermediate risk patient, and he plot those graphs for the brachytherapy, external beam, and surgery. If you look at those images, there is overlap area for all three of them. Of course, there is. However, the brachy stand on the top in this comparative analysis. This is not randomized trial, but this is the best evidence we can have. Now, external beam, you see the big range. And external beam, big range is because of multiple reasons. Because some people use hormone, other people don't use hormone. Some use lymph node, the other don't. And also some use in the past lower doses, and then later on the escalated doses come. And I would say that using all those combination, you probably get the result closer to brachytherapy. I would not claim one treatment giving better outcome than other, but you can see by the graph that brachy is standing out even from surgery. And if you look at why the surgery have such a wide range, for very simple reason, because surgery is by skills. So if someone have more number of experience or tertiary center or very experienced surgeon can have better outcome than to other. So this is prostate cancer study group results published in long time back, 2011, and comparative study for the low risk. And I would share the very similar graph here. Now here you can see some more, like you see surgery, you see external beam radiation, you see brachytherapy, but you see external beam brachy and seed as well. And as I told you that now RTOG study, I think 0232, if I'm wrong, apology. But that study proven that external beam radiation plus brachyseed implant is equal to only brachyseed implant in intermediate risk category, and actually less toxic for the brachytherapy alone. But this graph also showing very clearly standing out brachy as an option. And probably external beam is not doing as good intermediate risk. And again, as I told you, because they were using hormone or no hormone, or lymph node or no lymph node, low dose versus high dose, or dose escalation. The new factors will come in place, as Dr. Mohammad Shailan mentioned about the ultra hypofractionation as well. So I move on to next slide. This is my own experience from Cross Cancer Institute. And this is we did the post-implant dosimetry. We find D90 to be median of 153%. And you can imagine we want only of 100%. And this is very good achievement. With that, we reported our data in about 800 plus patients. Urinary toxicity was very reasonable. The most common was the urinary retention when we use the spinal. Therefore, I try to avoid spinal. And that was only for 1 day of catheter in 16.6% patient. However, TERP required in few patients, like the 17 patient, when the toxicity was very bad, and urinary toxicity and bladder. Rectal bleeding was only in 16 patients, which was cauterized and was healed. As I told you, most devastating is extravesical fistula, which happened in 2 patients out of about 1,000 patients. Therefore, I wrote 1 in 500. But when it happened, it is devastating, but it's very rare. I would talk about some evidence for trimodality treatment, very important topic, because now, before we were thinking prostate brachytherapy is the treatment for early stage or low risk and intermediate risk prostate cancer. That is completely changed when Ascend RT trial published. In Ascend RT trial, what they did actually, they give external beam radiation, 46 gray in 23 fraction. They did brachytherapy LDR boost, 110 gray, and they reduced the hormone duration to 1 year. You remember I mentioned to you with the dose intensification with using radiation, you can cut down the hormone duration. And that saved the patient a lot of metabolic side effects. So that's for that reason, this is now as a standard. We know about SNRT and we have the long-term data published. I just add one thing in here, a Japanese study, which is very fresh. It's not even published yet. It's just a pre-publication. I got hand on this article. You can find that on PubMed as well. This is going to publish in Red Journal on February 1st. This TRIP study from multi-institutional study, phase 3 Japanese study, and very important, they compare 6 months of hormone treatment versus 30 months of hormone treatment with exactly same treatment what SNRT was, external beam plus LDR boost of brachy seed implant 110 gray. And they found at the median of 9.2 year, which is long enough to assess, that there was no difference in the outcome. So I can tell you that by using the AscendRT data, you can safely give only 1 year of hormone treatment, and now even 6 months of hormone treatment after the TRIP study published. So by doing dose intensification, we can reduce the hormone treatment. And I feel very difficult if I don't offer brachy boost treatment to my patient who are high risk and eligible for brachytherapy. So please keep this in mind. It is no more a luxury to have the brachy in your center. It is actually a necessity for the prostate cancer patient. So it is must. These are the graphs you can easily find in the literature as well. This is Ascend RT trial where they did external beam radiation and dose escalated one, 78 gray compared to the external beam plus LDR brachy boost. And you can see that very clearly brachy boost is outstanding in the graph. Even I can pass through between those two graphs. I learned from one of a friend who was saying that if you can pass through between those two graphs, then this means it's a good difference. So that's I use the criteria. Same thing in here, like, what important point highlighted is that when we use that treatment dose intensification in very high risk group, the outcome was even better. So that's keep in mind that, it is going to be necessity for very high risk, but also for high risk as well. So this trimodality treatment, there's one very, very recent study. The reason I include it, it's not the best I want to include here, but I included the reason that Ascend RT or Japanese trial, they both use LDR brachytherapy as boost treatment. I was thinking, why not to use the HDR as boost with external beam radiation? So the Canadian come together and they did a phase 2 randomized multi-institutional study. This is between few centers in Canada, and all the authors we know. And then what they did actually, instead of testing the LDR or HDR brachy, they actually taken that external beam plus HDR brachy can be a standard treatment for high risk, and they deliver external beam radiation. They give the boost to every patient, HDR single fraction boost, and they give hormone injection between 0 to 6 months for high tier intermediate risk, and 12 months to 24 months at the discretion of physician for high risk as a boost, HDR boost upfront in the treatment. And then they randomize them into either ultra hypofractionated whole pelvic and prostate radiation treatment versus standard radiation treatment. So they give 25 gray in 5 fraction to elective pelvic lymph node, prostate gland, seminal vesicle in 5 fraction, alternate days, or they treat it like 45 to 46 gray in 23 to 25 fraction, standard dose fractionation. So this study was actually to establish that one single fraction of HDR is constant, and can we do ultra hypofractionation radiation to those patients in 5 sessions. And the study so far is only reported as quality of life. is a short-term follow-up with quality of life. And they said, yes, we can. So these were the arm of them, which you can find it. This is very recent and latest article. You can find them. And they treated actually 80 patients, both arm almost equally distributed. So with this now, I will move on to the next very important topic of the brachytherapy, which is local failure and salvage treatment. And I have to say that in my center, when I work hard to establish brachytherapy, this was the main reason. Is still we have options of surgery or external beam radiation for other options, but we have very limited option for local failure. They can have surgery, but it's not common. But the RTUG EORTC 0526 study established the very good role of salvage brachy in local failure. So when you have local failure, local recurrence proven by the biopsy, you have option of salvage surgery, salvage LDR brachytherapy, salvage HDR brachytherapy. You have salvage hormone therapy, which is only suppression for some time, and eventually patient develop the hormone refractory and metastatic disease. High fuse question mark, but it can be an option, but not available here. And also there are debate is going on when we do the brachy salvage, should we do focal salvage or should we do the whole lobe or we do whole gland? This debate is going on. To me, I did salvage brachytherapy in Canada on RTUG 0526. And also in my country, in Middle East, also we did brachy. Unfortunately, in my both cases, in this case, also the whole gland was positive for biopsy. So therefore, I have to treat the whole, but it's very tolerable. Patient have some follow-up as well with no complications or extra complication. So I want to show just a couple of slides where I'm co-author as well for the RTUG 0526 study, which will add in Canada, is a phase 2 prospective trial where we did the seed implant in patients who have external beam and they passed 2.5 years and they have the biopsy proven disease in their prostate gland and no metastasis on conventional imaging. Then we treated them with the full dose of brachytherapy, 140 gray, using LDR prostate treatment. And that study at 5 years, you can see disease-free survival of 61%, which is really good as second treatment. And the toxicity was also very tolerable. Only one tip in here, but I just want to give it here, but I can talk in the tip time as well. There is a talk about tips for the brachy. When you plan a brachy salvage plan, it has to be a cool plan. You can prepare a hot plan or you can prepare a cool plan. And the reason I'm saying that basically when we do brachy is actually a late boost rather than a recurrent disease to be treated. So prostate cancer dormant for some time, and some people need more dose than what we have given them before, and therefore they fail in the prostate. And what we are doing is a delayed boost in them. So you don't have to be over enthusiastic to really hit it hard. And that's what I did for my first 2 patients in the beginning, in my experience, get some more side effects in them. And when I cool down and I understand the process that this is not hit hard, it's only a late boost for these patients, then toxicity was very tolerable, actually close to nothing. So therefore, this tip is very important to tell you here. If you're planning a salvage brachy, any type, please go cool on the planning, not the hot plan. So with this, I will conclude my study, my talk for this part or this session. And this is for localized prostate cancer, we can be treated with brachytherapy, external beam, surgery, or combination. And brachytherapy plays an important role in management of prostate cancer due to dose conformity and better toxicity profile. Brachytherapy can be a primary treatment for a low dose or for low or intermediate risk prostate cancer, or in combination with external beam radiation for high tier intermediate to high risk prostate cancer. Brachytherapy is a convenient and cost-effective treatment and should be available. And I'm repeating that it should be available as an option in most centers in our region. And we are working towards that. With this, even though I'm finishing my talk for this, but I want to show you some few more minutes I'll take from you, show you some of the equipments in here, and also want to remind you again that you have to come back, re-log in next session using the new link, and that will be the for the afternoon session at 1:30 Saudi time, 2:30 for Oman or UAE time, and 3:30 for Pakistan time. And you can calculate for your region. I cannot take all name. There is a question from Dr. Abdul Qadir Jangda from Khan University in Karachi, Pakistan, that he's talking about the training requirement. So the training requirement for our center, when we initiated the program, Ms. Iqbal will mention in her talk, and the quality assurance will be talked by Nirmal Babu later next session. It was about 3 to 4 plans we did together with a Canadian physicist. I must mention her name here because she helped us, Geeta Menon from Cross Cancer Institute. And after that, we are doing our own plan, and also QA from the very beginning. We do all our QA for all the patients. Now, with this, I'll be stop sharing my window. I'll take off my background and I will take you to the equipment. So bear with me before lunch break. Okay. So here is me again, and I want to show you, this is ultrasound probe, which I was talking to you about. So this ultrasound probe is actually, it's from any company can be. However, it should have the capacity for the brachy seed implant. So there are 2 transducer here. One is horizontal and one is vertical. So vertical use for the vertical is used for the sagittal view, and the horizontal use for axial images. So we have both images, and we can switch between them, or we can have both images together. This is the ultrasound probe which we are talking about. This connected with this link to the whole ultrasound system. I did not bring the ultrasound system in this room, but it can go to the images which I showed to you before. So with this ultrasound, I talked to you that there is a stepper, and this is the stepper. So stepper have, a lot of movement. So we have a round thing in here in the stepper, and you can see that when we go into the prostate gland, we may want to go more deep in or less deep in, and that we can use by using the stepper. So we use the stepper. We can use this round thing to move back and forth within prostate gland. And here the probe will be sitting in here. So with that, probe will be moving around. So probe will be like this in this one. And this is the probe position. And if you look at, I can move the probe position back and forth. Okay. So this will be, by doing that back and forth movement, we're actually moving the prostate inside the prostate gland, but back and forth means going from apex to base or base to mid gland. So step 5 millimeter step. So that's what one of the probe is. Now, if you look at, there are lots of movement in here. We can do side by side. We can actually have lots of adjustment. If you want to move in, we can actually adjust the position of many things in here. So we can have every angle if we want. So with this, the probe, if you look at the template, which I mentioned to you, the 2 sides of it, so A, B, C, D up to G. And then if you look at, then you can be like this will be the A, B, C, D, and 1 to 6 and 12, we mentioned both sides. And this template have the holder, which can go into template holder here. So if you look at this, it will be in this position. So when I'm putting the needle from here, the needle go through the template, go to the prostate, and I can choose how far I can see that, and I can move, and I can focus. This is the way the whole seed package come. The seed package come in this pack, and I just open this package, which is sterile, and start implanting. On average, we may have 20 to 25 needles using about 80 seeds. These are the other 2 equipment. You see this? These are the frames which go onto the patient bed and which fix. And here is one of the important one to mention to you is actually this frame. So this frame here, where this will go, and we have multiple angle to move or shift or angle in the prostate gland. So these were the equipments I want to show with you. And these come in the like, the everything comes secure in the box, and I can take you around like, these things here. So most of the stuff I show you, which is used for the LDR brachytherapy. And with this, I come back to myself.